And how much does the AMA cap effectively on medical students affect the cost of healthcare? Because I know that doctors in Europe get paid a lot less, and a lot of people I know from parents who are doctors left to work in finance for that very reason, who grew up in places like France and Switzerland and Italy and Spain and places like that. And why does the AMA make it so impossible for young people to get into medical school? Is it really just so that the doctors can have the relatively high pay that they're accustomed to compared to other professions? Or and how much of that, if that is the case, drives healthcare costs higher?
I think that would certainly be a contributor, to the extent that's happening. I think a shortage of medical schools, at least by my understanding. I know for sure, and from my vantage point as a venture capital investor, you hear from every provider organization about workforce shortages, not just doctors, but even including less credentialed providers such as nurses, shortages across the board. So I heard anecdotally in many cases during COVID, nurse and especially contingent labor, so travel nurses, were starting to be paid more than some doctors, right? Not neurosurgeons, but family physicians, for instance, because there's such demand and such a shortage. So again, that I think some of that's market forces, and I think, Nick, your question around, let's think about the supply side is really important. How can we bring more people in medicine? This is exacerbated. I've heard more, frankly, let's call it kind of, there are sticks and there are carrots, right? And if medical school, the difficulty of getting into medical school, maybe that's not a stick or a carrot, but like a gate or something. But once people are a doctor, say, many doctors are burning out. They left the profession during the pandemic, and other providers are burning out. And plus you have the boomer generation, the so-called silver wave that are reaching retirement age now. So as that very large demographic begins to retire, that's going to exacerbate the workforce shortage problem. So we hear that from all provider organizations, that this is a big deal, and therefore they really need to invest in workforce automation wherever possible. The difficulty, of course, is you can't really automate a doctor fully these days, but certain pieces of legislation like meaningful use around electronic health records that said, basically mandated, right? And this was, I don't think necessarily was part of Obamacare, but right around the same era, that you provider organizations must use electronic health records. And here the benefits would be. Largely, the clinician, the individual clinicians, by and large, intensely dislike their experiences working with the dominant electronic health record products, which were written on software stacks that are 50 to 70 years old. So the number of clicks required to kind of do your basic work is again an order of magnitude or two higher than what we're used to with modern software products. We see opportunities for AI to kind of fix this, as well as fire data interchangeability standards, et cetera. We have some investments in this space, but those are some of the things, Nick, that I see contributing to the lack of supply of provider labor. And I think your point around kind of medical schools and the profession controlling that supply, I don't know as much about that, but I think it's an interesting question.
And then with the rest of the world apparently subsidizing the US, and maybe I think Switzerland and other countries, a net positive creator in healthcare innovation. Is there a policy solution to get these countries to pay like their fair share, the single payer ones, in innovation? Otherwise, if the US went single payer, would we just basically have an effective cap on health spans because nobody would bother to put in the financing to develop any new sort of innovations in medicine.
So that, admittedly, this is another area that I think it's a fascinating question. I don't know enough about it. One would assume, so clearly in the US, there's a wonderful chemistry that's productive of innovation of all kinds, not just in healthcare, but across the board. The number of startups that are founded, the number of unicorns that kind of come into existence, there's no economy quite like it. And so a part of it is the generous subsidization, if you will, due to how healthcare is paid for, and new drugs and devices, the incentives to develop them are very rich. It's true that even European, for example, device and drug makers, often really their end game is to get into the U.S. market, right? they want that FDA approval or clearance to really make the kind of money that they hope to make. So I think that said, if you were to look at it on a per capita basis, what is the actual statistical difference between a single payer system, like a sophisticated economy like the UK, Switzerland, Germany, France? If you took a look at those countries as on a per capita basis, what's the innovation impact, if you will, of a single payer approach to the US system? And I haven't done enough research on this to know. But one would assume the US would still be ahead because of the way we subsidize this, but I've heard people claim that that's not the case. I just came back from Switzerland last week and met with a couple of pharma companies there. Of course, pharma is one of Switzerland's key economies, and you have a number of great companies, large pharma companies out of Switzerland. I met with a biopharma company in Lausanne in a new life sciences development park called Biopole in Lausanne, and I believe the canton has invested something like $500 million in developing this Biopole, which is meant to be like the Research Triangle Park of Raleigh Durham, triangle in North Carolina for Switzerland, and it's an impressive place, and was impressed with what I saw. So I think it's a good question. I don't know the answer definitively as to how things would look different. Would the people that are incorrigible entrepreneurs these days kind of lessen their activity if taxes were higher and it was kind of somewhat less monetarily rewarding for them to pursue innovation? I'm certain those incentives would have an effect. The magnitude of that, hard to say for me. So
the next question I have in terms of drivers of the healthcare cost spread is how much does the fact that the US has a materially higher obesity rate than most other developed nations, with the exceptions being, I think, Canada, the UK, and some of the Gulf states and Mexico have similar levels of obesity to the US. But how has that impacted the cost spread? Because I think that's a big driver of the US having a much larger population, but also a much larger obese population.
Yeah, I know. I think that's a good point. I do know that the big chronic conditions, diabetes, heart disease, cancer, COPD, drive and complications related there too, drive something like 70-80% of healthcare spend. So certainly lifestyle factors play an enormous role in each of those chronic conditions. With diabetes, you have type 1, which is congenital, and type 2, which is late onset and often avoidable or reversible, depending on lifestyle choices. I think the statistics around type 2 diabetes are about 30 Americans have been diagnosed with type 2 diabetes, but I think that the estimates are upwards of 60 million might have diabetes or pre-diabetes. So I think it's another 30 million on top of that might have pre-diabetes. So again, the cost burden, the US has just over 300 million people. So
340 to be exact. Yeah.
340. So that's a significant part of the population that that is a risk for that. And no, I think that's a major driver. And I think an interesting comparison
like if America had the same overall health as like Colorado, which I think is the only state whose obesity rate is under 40% or under 30%. If America overall was as healthy as Colorado, would we have a similar percentage of healthcare spend to GDP as European countries do?
Well, I don't think that health is the only driver, as we've discussed, right? Yeah. I think it's multifactorial. But I think that certainly that would help lower costs for sure. Yeah.
And then the other component is this is similar in fields such as education and just government bureaucracies in general, which are in other industries that are heavily regulated or have quasi like governmental controls on them. They tend to have the most inefficient labor forces compared to other industries that like such as software and technology, which have relatively lean workforces. Is the healthcare industry and education industry and a lot of these other semi-protected industries, essentially the role in society is to be middle-class job providers? Like if you look at, say, like a Rust Belt city like Syracuse, New York, or Columbus, Ohio, or something like that, where a lot of their factories were gone. Those jobs essentially, like you look at the biggest employers in all of these Rust Belt cities now, they're healthcare facilities such as hospitals and distribution centers and things related to providing care. So is healthcare essentially the reason why it's inefficient? Is it's intentionally so to be a jobs program for people who otherwise they wouldn't have a demand for in a more free market economy? Or am I a little bit conspiratorial here?
I think that's a really interesting question. I mean, and yes, clearly these provider systems are the largest employers in many parts of the U.S. And so a couple comments, right? One, there's a book I read called the America's Bitter Pill, I think it is, written by Stephen Brill, who's a journalism professor at Yale and wrote a book on healthcare costs. And one of the things that I recall from that book is he looked at the status of most hospital systems or health systems as being nonprofits. So these are nonprofit organizations mostly, which can't distribute profits to shareholders, right? So where do those profits go? They go into the latest and greatest MRI machine or CAT scanner or remote surgical tool or whatever, right? Or infrastructure, new campuses, shiny new buildings, right? So they have you been to Cleveland, Ohio?
No, I've never been to Ohio at all.
So I went to Cleveland a couple of years ago when I was with Econos and spent some time there. And what struck me about Cleveland is just how multi-tentacled the Cleveland Clinic is in Cleveland physically. Its physical footprint reaches across the entire city and most of the suburbs. It is enormous. It's enormous. and it's also a destination health system, right? They're known for, I think, mostly cardiovascular care. Certainly Mayo Clinic is. And so people come in from all over the United States and all over the world to Cleveland. It's a big part of their economy. But a lot of the system's nonprofit status ensures that they're plowing their profits back into infrastructure, and that increases their overhead costs, which they have to pay for by funneling people to high reimbursement procedures. Right? Not all procedures are created equally. Some are a lot more profitable performed than others. These are known as profit centers within health systems. And then you have kind of loss makers within health systems. Economically, those don't necessarily match, by the way, to the best healthcare choices from a purely clinical standpoint. So, for example, implanting catheters in people is a very profitable procedure. So I've seen estimates from healthcare economists suggesting that there are about 30% more catheters placed into patients than should be than a purely clinical strategy. And this seems to be driven by the economics of cath labs. This is a profit center for most health systems. So there's a mutually reinforcing process there of nonprofit status leads to reinvestment, leads to higher overhead, leads to a need to charge more to cover costs, right? And then pair that with the silver wave of a massive number of Americans that are getting older, and who's, I think, again, 80% of healthcare costs occur at the end of life or the very beginning of life. Neonatal intensive care units and end-of-life care, because that's when people are really sick, right? Really sick, like in an inpatient way. And so that points to another set of factors, right? I'm worried about what's going to happen to these systems and hospitals when the silver wave passes. That I think is something that we as a society need to plan carefully for. Yeah.